We begin today's lecture. The topic of the lecture is traumatic shock. So, what is the concept of shock? Shock is exactly like a medical pathological situation. Shock in our understanding is a typical process. Typical in terms of the fact that there is a fairly large, say, variety of types of shock, and we will see it on the next pile. In some cases, in particular, today we will analyze traumatic shock. This is a phase-developing pathological process. And in our case, from today's topic of traumatic shock, it is a process that pathologically occurs as a means of disrupting the nerves of the humoral regulation of our body. In essence, problems with the adjustment of regulation, namely with humoral regulation, with nervous regulation, are the root cause of most shock states, which later, of course, have a very similar pathological cause. So, back to the definition. Shock is a typical phase-developing pathological process that occurs due to disorders of neurohumoral regulation and is caused by extreme exposure. Moreover, in our case it is a mechanical injury, traumatic shock. We can talk about a burn injury, and there is a separate subspecies of shock with its own characteristics. This is a burn shock. Electrotrauma, which essentially presents itself as a thermal effect, and an electrical effect on our tissues and so on, can also be attributed to one of the subspecies of traumatic shock. So, what is the concept of extreme impact? It should be regarded as an exorbitant impact, that is, an impact that will essentially exceed our compensatory capabilities of the body. So, shock is a typical phase-developing pathological process that occurs as a result of a disorder, primarily of neurohumoral regulation, caused by an extreme exorbitant effect on our body. In the case of traumatic shock, it is a mechanical injury and characterized by a sharp decrease in blood supply to tissues, disproportionate to the level of metabolic processes. That is, in this case, we have the development of hypoxia, a shortage, say, the supply of oxygen in the tissues, and, as a consequence, the suppression of the body's functions, and the total of almost all the functions of the whole organism. So, a brief digression into history. The doctrine of shock has more than 200 years. The term, in essence, comes from the French word la chique, blow, concussion. It was proposed in as much as 1737th year by the French surgeon Le Drape to denote a severe general condition associated with loss of consciousness when wounded. That is, as you understand, it was the traumatic shock that was described first from a medical point of view. It should be noted that the general changes that occur in a person after an injury have been known for a long time. Since ancient times, there has been a description of shock in the works of Hippocrates, in the works of Celsus, the reception of traumatic shock. In this case, in this lecture we will focus on traumatic shock, which, well, is most often found in the surgery section, in the traumatology section. In fact, there are quite a lot of types of shock, or, as they are commonly called, types of shock, since this is a typical process, and one of the subtypes of traumatic shock, as previously mentioned, is burn shock, a shock that occurs in response to thermal trauma. It has its own specific features, its specific clinical manifestations, slightly differs in pathogenetic terms. Further on in the lectures, of course, we will consider this hyperbolic shock, as it is now commonly called, or, as previously said, hemorrhagic shock. We discussed it at the last lecture. This is also one of the types of shock. In the section of internal diseases, you and Andrei Alexandrovich will definitely analyze cardiogenic shock that occurs in response to, well, serious GRAS, let's say, a serious pathological process for a transmural infarction, and for a phylactic shock. Yes, a shock developing in response to a disproportionately violent allergic reaction. Geoinvasive or hemolytic shock, we will try to sort it out in the scope of clinical transfusiology, in the scope of self-preparation with your groups, in your reports, and you will definitely sort it out next semester, when you pass the discipline of resuscitation of anesthesiology. Another of the subspecies of shock is infectious toxic. We also meet quite widely now against the background of various infectious problems that our country is facing, which is not even of the last importance. Let's try again to sort out a little other definitions of shock, well, exactly in the aspect of traumatic shock. So, traumatic shock is a general reaction of the body that develops in response to trauma, and to an exorbitant, as we have already said, trauma. You are characterized by a disorder of vital functions of the body. In particular, it is mandatory that these are the functions of blood circulation, definitely the functions of respiration, metabolism, and the activity of the endocrine glands. This disorder is expressed in the development of acute cardiovascular, acute respiratory failure, in the development of hypoxia, and total hypoxia of all organs and tissues of our body, and in the development of metabolic acidosis, which is not, well, say, the main importance in the development of serious biochemical problems on the periphery and in tissues and, as a consequence, to the development of what will lead to DIC syndrome and subsequent microcirculation disorder. And as a consequence of the disorder of microcirculation of the tissue to the disorder of the entire hemodynamic system, the entire system of tissue respiration. Yes? So, what is the cause of traumatic shock? Well, naturally, we are, as they said, in an exorbitant mechanical injury, a trauma so powerful that it exceeds the compensatory capabilities of the body. Of course, there is a concept and meaning of the severity of the injury. There are no certain digital norms that you can measure the whole thing. That is, the severity of the injury depends, of course, on the occurrence of shock, from the strength, from the duration of pain irritation, which will subsequently overexcite our central nervous system. Definitely, the occurrence of shock depends on some predisposing factors. If we say that the transcendental view, the impact from the point of view of pathophysiology, is an impact exceeding the compensatory capabilities of the organism, then it must be said for sure that the compensatory capabilities are always different. Therefore, there are a number of aggravating factors, we will talk about them later, which can contribute to the occurrence of shock. Well, for example, this is hypothermia, this is already existing blood loss, this is fatigue, various diseases that are present in the human body, which is subject to the very exorbitant mechanical injury. Definitely, the purity of the shock will depend on the place of injury, because there are certain areas with a greater, let's say, tendency to develop shock. Yes, the so-called shockogenic zones. The question of the epidemiology of shock. Traumatic shock occurs quite, well, not often, with serious injuries that are worthy of inpatient treatment in an average percentage, on average about 3% of all cases of injuries. Definitely traumatic shock is more common with combined and multiplied injuries. There is data indicating 8 to 15% of injuries that may be accompanied by traumatic shock. The mortality rate in this pathological condition is high. The data vary quite a lot, and in different sources there are figures from 25 to 85% of states of traumatic shock, which, unfortunately, ends in a fatal outcome in the final. So, what factors can lead to the development of traumatic shock? The predisposing factor is hypothermia, overheating of the body, physical fatigue, starvation, hypovitaminosis. In the case of radiation damage, naturally aggravates mechanical injury. The absence and insufficiency of embolization in fractures and extensive injuries can provoke the development of shock, not necessarily even at the time of injury, at the time of transportation, or at the time of shifting from one car, for example, sanitary, to a stretcher in the emergency room of a medical institution. Long-term, not sparing transportation. Various options for additional injuries, including surgical injuries. As we have already said, the shock depends quite seriously on which zone we injure. So, the most shockogenic zone in terms of the occurrence of shock are pelvic injuries. Therefore, there is a clear explanation: this is still a fairly extensive receptor zone. The pelvic plexus is a very powerful plexus, a sufficiently large volume of vessels that can be injured in this case, and plus the spongy bone itself, in case of its fracture, provides a large amount of blood loss. In total, all this leads to the fact that about 1/5 of all types of traumatic shock are caused by trauma from the pelvic area. The 7th part of all types of shock is caused by abdominal trauma. It's also clear, right? There are quite a lot of organs of good innervation and very frequent damage to the parenchymatous organs in this case. Every 20th shock, that is, 5%, is a fracture of the largest, probably, bone of our body, a fracture of the femur. Let's move on to the pathogenesis of traumatic shock. From physiology courses, according to this physiology, you remember that the body is a self-regulating system, and in response to any external aggression, neuroendocrine responses, metabolic responses occur. If the external influence did not exceed the compensatory capabilities, then the responses eventually lead to a complete concomitation of the developed disorders, and if the stimulus exceeded the limits, we have already discussed this when considering the theology of shock, then a disorder of self-regulation occurs, leading to dysfunction of all vital organs and systems of our body, to a disorder of homeostasis, and in the final result is the development of the very phenomenon that we call shock. In the process of developing medical knowledge, there were quite a lot of different theories of the pathogenetic development of shock. This is the so-called toxic theory, vasomotor theory, trench theory, the theory of loss of blood plasma, the Cipater adrenal crisis theory, as well as the theory that our compatriots are the authors of. This is the theory of neuroreflective. At the moment, of course, it did not even occur to anyone to refute any of these theories. They are really absolutely reasonable, they describe everything correctly, but at the moment there is a complex theory that includes almost all the thoughts that have been stated by various authors. They are very well linked into a single whole and allow us to understand at the moment what shock is, in particular traumatic shock. So, let's start with one of the first. This is a toxic theory. Its author is a French scientist with the surname Quenu, according to which severe disorders in the body during shock are caused by poisoning by the decay products of tissues, in particular by the decay product of muscles. Intoxication leads to a violation of microcirculation, to an increase in vascular permeability, to the deposition of blood in tissues, a decrease in the volume of the central nervous system, metabolic disorders, and rapid death of the victim. Indeed, such things are present in shock. The theory of the British scientist George Creve, called the vasomotor theory, assumed the explanation of shock as a result of reflex paralysis of peripheral vessels as a response to trauma, which led to a progressive drop in blood pressure, blood deposition in the venous bed, and this all leads to disruption of blood supply to vital organs, to the development of structural and functional disorders, death of the victim. Also, the theory is of course confirmed. Another rather interesting theory was proposed by Henderson, a native of that American continent, the theory of the trench. The theory of Copnay tried to explain the development of shock by a decrease in the level of carbon dioxide in the blood as a result of hyperventilation of the lungs in pain, which is really observed, and it is observed in the very phase that we will call erectile, and we will talk about it later. It is present in traumatic, in burn shock, but it does not occur in many other shocks, so, probably, after all, the theory is very half-hearted. So, hyperventilation of the lungs as a result of overexcitation of the body is accompanied by a violation of metabolism, a violation of the acid-base state, the development of cardiovascular insufficiency, a disorder of homeostasis, microcirculation due to stagnation of blood, the development of metabolic acidosis in tissues. A little strange, a little incomprehensible. The essence of this theory is completely, of course, shock cannot explain, but some aspects of it are definitely present in the process of shock pathogenesis. Another theory is the Alfred Blalotka theory, Kober theory, and plasma loss. But, following this theory, the leading pathogenetic factor in the development of shock is considered to be a decrease in the central nervous system. And indeed, it is. As a result of blood loss, trauma, and to a greater extent it is characteristic of hypolimic or hemorrhagic shock. In injured tissue or as a result of plasma loss as a result of increased vascular permeability, this is present in all forms of shock, there is a sharp decrease in the central nervous system. As a consequence, severe hemodynamic disorders lead to irreversible changes in vital organs. Sympathadrenal crisis. So, the theory of Hans Seeley, who suggested the following, that as a result of traumatic shock, the anterior pituitary gland is functionally depleted by the adrenal gland. And indeed, After some time, as a result of the release of a large amount of those biologically active substances for which these organs are responsible, they become so. As a result, there is a hormone-deficient state in the body, and as a consequence of all this, he believed, the development of all other pathological reactions. Some parts of the theory, of course, are correct, but in total, a lot of things have been missed that can be inserted into the pathogenetic series between the phenomenon of, say, a sympathetic adrenal crisis and the phenomenon of the shock itself, which will develop in the final. Our domestic Russian theory is a neuroreflex theory. Neuroflex theory says that according to it, shock is a general reaction of the victim's body and the occurrence of the development of which involves the higher departments of the central nervous system. The theory was formulated by Pavlov, supplemented, generalized and, let's say, systematized by the domestic surgeon Burdenko and, in particular, it is believed that the flow of nerve impulses coming from the injury zone, and an insanely powerful flow, an exorbitant flow of nervous impulses leads to overexpression of the nervous system, in particular, the central nervous system. As a result, exhaustion occurs after some time. Depletion of the presence of neurotransmitters on the sinuses, which involve the transmission of information in various parts of the central nervous system and, as a result, protective inhibition develops. Yes, with the subsequent prohibitive braking. And as a result, these authors, believe that all this leads to shock, again, as a triggering aspect of the theory. Of course, all this is true, as a situation that will lead to the most serious disorders occurring both on the periphery in tissues and in the intracellular environment, and, accordingly, in the hemodynamic system, in the body's regulation system. This is only a half-hearted view. The look, probably, which can be considered the cause, the beginning of a traumatic shock. So, let's move on to what will be called the combined theory. Let's try to combine all this into something unified. Mechanical damage causes severe pain irritation, accompanied by arousal, overexcitation of the cerebral cortex. As a consequence of the transfer of further information from the central deeper, specifically gyrus, then to overexcitation of subcortical centers that affect the pituitary gland. You understand that the thalamic zone is excited, the hypothalamus begins to release releasing factors, as a result, the pituitary gland is excited, after which the pituitary gland begins to intensively produce tropic hormones, in particular, adrenocorticotropic hormone, which accumulates in the blood and begins to stimulate the production of catecholamines in the adrenal glands. Catecholamines, entering the bloodstream in large quantities, begin to affect alpha receptors, which are located in the smooth muscles of the vessels. In particular, it is the capillary leaders that react to a greater extent. Leading capillaries lead smooth muscles of arterioles and slightly less smooth muscles of venules. Larger vessels, as you understand, or veins have a very weak muscle wall, but as such, they are more elastic and powerful, they are not even inherent. In this case, direct arteriovenular shunts are opened. Yes, this method involves the discharge of blood in order for it to return to the venous channel faster. The blood bypasses the vein, the blood bypasses the capillaries, and thus, the reflex of centralization of blood circulation is just carried out. But that part of the blood that has stopped in the MIC church channel with all our desire remains there. Pavlov's theory in action is present here. Over time, the adrenal glands are depleted. I think this is also understandable. Hypoxia begins to develop in the tissues deprived of blood supply on the periphery. Acidosis begins to develop, toxic products begin to accumulate, because the cells of our body require oxygen in order for us to have energy production in a full-fledged way. If you remember the section of biochemistry, our first or second year of your training, then the process of obtaining energy from a universal source, which is glucose, is the following. That is, we take glycogen, split off glucose. As a result, without the oxygen pathway of glycolysis, we get two molecules of ATP and lactate. Lactate in the presence of oxygen in a mechanism called the Krebs cycle is eventually converted into carbon dioxide and water in the final. But as a result, we have 36 more ATP molecules, the universal measure of energy up to the intracellular medium. By depriving the cell of oxygen, we reduce the efficiency of energy production by 18 times and lead to the accumulation of lactate. The products of this very thing, lactate itself, is quite toxic as a result of all our, say, actions related to hypoxia. After some time, peripheral tissues begin to suffer. Atony sets in. It is also not possible to keep the vein constantly in a vessel spasm. After some time, the arterioles expand. Capillary sphincters also open, but blood is deposited in the capillary network at the periphery. Externally, all this can manifest itself as cyanosis. Cyanosis of the skin, because only they are visually accessible for our observation. After some time, the decentralization of blood circulation develops, yes, and begins to decrease in the central committee due to the stagnation of blood in the same capillary bed. She can't go any further, and she can explain it. Next we will talk about the situation of coagulopathy, about the situation that the microcirculatory bed as such is clogged and it is not possible for blood to flow through it. All this leads to a progressive decrease in blood pressure. This slide shows a schematic representation of the pathological processes that begin to occur in the body. Please independently review your knowledge on each item approximately. Refresher. Recall all this from the course of pathological physiology and then move on to the next slide. Here you are presented with a rather interesting reasonable definition of shock by the authors Shipkov and Borisov. So, a traumatic shock should be regarded as a microcirculatory and energy catastrophe with a complete imbalance of the coagulating anticoagulation systems of the blood, with insufficient transportation, delivery, and utilization of oxygen, with an acute violation of the oxygen transport function of the blood, with a sharp decrease in cardiac output, with the mandatory formation of DIC syndrome, that is, the syndrome of disseminated intravascular coagulation, which can be a direct cause of multiple organ failure. A little further we will analyze all this in more detail to make it clearer. On the slides earlier, we stipulated this situation, that as a result of a large, catastrophically huge injection of catecholamine into the bloodstream, a spasm of small vessels occurs, in particular, first of all, a spasm of arterioles. As a result of the fact that adrenaline acts on alpha receptors, this is what happens. The distribution of alpha receptors in terms of our blood vessels into the body is represented unevenly. There are quite serious explanations for this. For the sake of this very centralization of blood circulation, most of the recipes are not located in those organs that are vital for those purposes, so that as a result of centralization, the vessels of vital organs are expanded, left passable for blood. Alpha receptors are few in the brain, alpha receptors are few in the heart, a slightly larger number, but also small, is contained in the liver, kidneys, lungs. The largest number of alpha receptors are present in the skin and, as you understand, the first organ that begins to turn off from the bloodstream as a result of spasm of small vessels is the skin. We clearly see this in the clinic when we observe a patient who is pale, yes, apathetic. There are few alpha recipes in muscle tissue. This refers to the skeletal musculature. The same thing, as a result of the development of shock, a person experiences excessive weakness, the muscles are not ready and are not able to contract and engage in their function. There are quite a few alpha receptors in such a visceral organ as the intestine, and the organ is huge and its blood supply is very massive. As a result of the shock, this organ is turned off from the bloodstream as well. There are a lot of alpha receptors in adipose tissue and here, in our case, adipose tissue, omentum, subcutaneous fat, and this is our depot. Depot of cellular elements, depot of tissue fluid. But, unfortunately, this organ will also be turned off as a result of arteriole spasm. Yes, as a result of art spasm, blood flow is directed through shunts, through the artery, venous anastomosis and capillary circulation in these tissues slows down. Under these conditions, blood, which is a suspension, yes, of cells and particles, that is, cellular elements suspended in a colloidal plasma solution, loses its stability. The so-called welding syndrome or coin column syndrome is formed. In the microcirculatory bed, the erythrocyte becomes like coin columns in a row. It really begins to resemble microtrons, and this is accompanied by a natural reaction of the body. That is, on the one hand, due to the fact that cellular elements accumulate, they do not pass the top further, the permeability of capillaries begins to increase. This leads to extravasation of plasma into the external environment. In the external environment, as you understand, there are also a number of serious changes. This situation begins to be regarded by the body as an attempt at thrombosis. What happens next? Stopping blood flow in the vessels of exchange, that is, in the microcurrent channel, that is, in the capillaries leads to tissue ischemia. Has tissues in service with these capillaries in the zone leads to the fact that, as already mentioned, we cannot reproduce energy by the classical aerobic pathway using the Krebs cycle. Only glycolysis remains. That is, tissue respiration is rebuilt according to the mechanism of glycolysis, and the tissue, the cell, tries to live only taking into account, let's say, 18 times less efficient energy formation. Naturally, acidic metabolites accumulate. The end of this situation will be extremely unfavorable. After some time, the cell will die, the cell will collapse, a huge amount of biologically active substances contained in the cytoplasm will begin to enter the intercellular medium. We will also begin to rebuild the ionic composition of the intercellular medium, because a large amount of potassium, a large number of other ions inside the cells will get into the intercellular medium, a large number of various organic compounds will get into the intercellular medium. At the same moment, fibrin begins to try to settle on the stopped erythrocytes, yes, on these aggregate coin columns. The answer is to turn on the fibrinolytic system of our body, which is triggered. Instead, a new one begins to precipitate, because the fibrinolytic system, naturally, enters into response, the coagulation system starts. As a consequence, there is a cognopathy. There is no blood loss, there is no damage to blood vessels, but, say, the balance between the formation of fibrin and fibrinolysis has already been disrupted. There has been a coagulopathy, which in the final can lead to the most serious things, to the syndrome of dissipated tricascular coagulation, to the DIC syndrome, and this is the thing that we call shock and is called in as a result, probably, the death of the patient, if we do not take the person out of shock. True erythrocyte aggregates accumulate in the capillary and turn off a sufficiently large volume of blood from the general blood flow, the so-called blood sequestration, yes, plus a significant section of blood is reduced in the central committee. The liquid fraction of blood begins to sweat through the vessels and go directly to the tissues. And the reason for this is that, as we have already said, a large number of ions accumulate in the interconvex space, where hypersmolation pulls water there. A large number of organic molecules, proteins, and so on accumulate in the interconvex space, which each of these molecules has its own oncotic properties, binds water molecules to itself with its properties. As a result, there is a kind of bleeding of own vessels. Yes, that is, we have blood loss without actually bleeding as such. After some time, we have a generalization of lesions of various systems and organs, yes, as a result of microcirculation disorders. At the same time, the degree of damage to various organs is not the same. As we have already said, the brain and myocardium are the last to be involved in the lesion reaction, since there were practically no alpha receptors in their vessels, and therefore capillary spasm and, as a consequence, capillary blood flow disorders in these organs were not observed at the beginning of the shock-related problem. Yes, the violation subsequently occurs, but not as a result of arterial spasm, but as a result of deep generalized disorders of general hemodynamics, respectively, with a decrease in perfusion in these organs and as a result of metabolic disorders, that is, general hypoxia of the body, general shifts in the pH of the whole organism, and the rest of the organs, unlike the amyocardial brain, begin to suffer much earlier. What happens next? So, the fourth and last stage of the pathogenesis of shock is characterized by the development of local necrosis in organs, in the intestine, liver, kidneys, pancreas, and heart due to violations of the cellular lysosomal membranes. Cell destruction occurs. Rheological disorders throughout the body haunt a person. That is, in shock, this leads to the occurrence of shock lung syndrome, shock kidney, and shock liver. You remember, we said that in these organs alpha prescription came and a small amount, but therefore there were problems with violation of microcirculation circulators in these organs, and these are vital organs. Unlike, say, some skeletal muscles, they were present. There are changes in the coagulation system. We talked about the fact that hypercoagulation occurs with the development of DIC syndrome. All this leads to the fact that hemorrhagic syndrome begins, that is, a total violation of the blood clotting system. The acid-base state is disturbed. With shock, as you remember, acidosis develops. This causes a violation of the contractile function of the myocardium. You have a dilettante stance, a decrease in the allocated kidney functions, and a violation in the work of our central nervous system, that is, a violation of the higher nervous activity of a person. So let's talk about the three vital organs of our body, the lungs, kidneys, and liver, which suffer from shock. Let's start here with the central part, with the liver. So, with shock, necrosis of liver cells, that is, hepatocytes, is possible. All this leads to a decrease in the synthesizing function of the liver. You remember, the liver produces proteins, to a decrease in the detoxification function of the liver. Remember the first theory of the development of shock? Yes, the theory of Kinnew, who said that intoxication kills a person precisely with shock. Indeed, it is. Liver dysfunction in shock can be judged by the concentration of liver enzymes appearing in blood plasma. You remember, yes, ALT is starting to grow in our country. Experiments that are present in different cells, but there are many of them in the liver. In addition, the level of bilirubin in the blood begins to rise, which indicates the death of hepatocytes. Cancer of consequence. The death of hepatocytes means a violation of liver function. Kidneys. What happens to the kidneys? The condition of the kidneys in shock is characterized by a sharp, limited decrease in blood circulation through the kidneys. The kidneys are the organ that is in pain. We have the largest amount of blood pumped through it. A third of all blood, yes, which the heart throws out, is pumped through the kidneys. As a result, the blood is filtered, yes, after which primary urine appears, which is concentrated, and in this way we remove nitrogenous slags from the body, we remove protein processing products. As a consequence, as a result of impaired renal perfusion, the function of urine formation decreases. In addition, the kidneys themselves, of course, are also in the pernicious situation in which the whole body is faced. The death of nephrocytes begins, and, as a result, the work of the kidneys also worsens at the level of their own vital activity. Here, the concept of blood pressure, which decreases in our body, is quite important. There is a certain qualification, a certain limit. This is 70 mm of mercury. Based on these figures, we have an understanding of filtration through the renal membrane. More than 70, urine is filtered. Less than 70 mm of mercury, primary urine is not formed at all. Conclusion: we lower blood pressure, we get alloguria. Reduced below 70 mm of the standard column, we get a more serious phenomenon. Anuria. Anuria, alloguria is, as you understand, an accumulation of toxins, toxic products of protein breakdown in the body. Conclusion: the more vicious the circle, the more the pressure drops, the worse the kidneys work, the more toxins accumulate. And the more toxins accumulate, the faster the kidneys die, the faster the pressure in our body will drop. In general terms, the stronger the shock occurs. Later we will talk about the severity of the shock. So it must be said that the figure of 70 mm of mercury is the boundary between a moderate shock and a severe shock. Sometimes this figure is called an irreversible shock. And the reason is that if we do not change the treatment program now, we will not, let's say, activate our medical actions in terms of saving the patient. Then if we fall below 70 mm of mercury column of real pressure, the vicious circle will turn on and it will be extremely difficult to get the patient out of this state in this case, or he will die. What happens to the lungs in shock? Hypovolemia in shock leads to a decrease in pulmonary blood flow. Lungs in shock, yes, are characterized by a violation of oxygen absorption. That is, we reduce the prosocial oxygen pressure in arterial blood as a result of the fact that the lungs work worse. But the lungs are also set in motion by the musculature, which, you remember, we suffered in this case. Conclusion. In addition, the tissue itself is light, then the lung is also alive, it requires nutrition, and here the same thing happens directly, say, nutrition of the lung tissue. All this leads to edema in the lung tissue, to a decrease in the elasticity of the lung. Conclusion. Pulmonary edema, the permeability of the pulmonary membrane is impaired. Less and less blood, less and less oxygen from the external environment begins to enter the blood, and as a result, it spreads throughout the body. If it is less, it means that the whole body is eating worse, so the shock is getting worse. And the shock is getting worse, in the final we begin to have the same aggravation of the work of the muscle tissue that drives the lung. And again, this leads to a vicious circle. On the X-ray, pulmonary edema is presented in the form of insocial pulmonary edema. The lung becomes rough, the lung becomes less elastic, and in order to straighten it, you have to put more effort. So, the pathogenesis of traumatic shock goes through the following stages. The stage of the neuroendocrine reaction, consisting of the stages of stimulation, that is, re-irritation, subsequent exhaustion and disorganization of the neuroendocrine regulation of the whole organism. The hemodynamic stage, which goes through the following substages: vasoconstriction at the beginning, blood stagnation, and the development of DIC syndrome. The metabolic stage is divided into hypoxia, subsequent fermentation, and irreversible cell damage. At the same time, it must be said that all stages are interrelated, interdependent, and proceed simultaneously with a gradual increase in structural lesions from the biochemical to the anatomical clinical level. Let's move on to the clinic. What is the clinical picture of traumatic shock? As mentioned earlier, shock is a phase-current pathological condition. The first phase of traumatic shock is called the arousal phase, or, as it is commonly called, the erectile phase. It usually lasts a few minutes. In some cases, there may be more. For example, with burn shock, the erectile phase usually lasts a little longer. With a very severe injury, the erectile phase cannot even be detected, not caught. A person immediately begins to plunge into the next phase, the torpid shock phase. The clinic is determined by the disorganization of various departments of the central nervous system. It is at this moment that overexcitation of the cerebral cortex occurs. The patient is most often conscious, his face is pale, his eyes are restless, the person loudly complains of pain, screams. There is speech excitement, short hurried phrases, confused thoughts. Sometimes the patient is in a state of euphoria, he is not aware of what is happening around him and often makes quite heroic attempts to do something. He can run with broken legs, he can rush into battle with huge wounds on his body, and so on. The condition somewhat resembles a state of alcoholic intoxication. The more pronounced the excitement in the reactive phase of shock, the harder the torpid phase will flow in the future and, of course, the worse the prognosis for the patient's recovery will be. At one time, the classical description of the erectile phase was given by Nikolai Ivanovich Pirogov. Let's try it out. If a strong scream, moans are heard from a wounded man whose features have changed, his face has become long, convulsive, twisted, pale, bluish, swollen from screaming, if his pulse is tense, fast, breathing is short and frequent, then whatever his damage, you need to hurry with help. Well, in this case, you see, the clinic is described. The character is pale, with a bluish, swollen face from screaming, that is, he really screams, his pulse is tense. This indicates that blood pressure is rising, pulse is coming soon. This suggests that in this case, in addition to an increase in blood pressure, emergency, shortness of breath increases, that is, it breathes more often. These are the clinical manifestations of the erectile phase of shock. In the future, the torpid phase of shock occurs, the phase of inhibition in this case, as described by the Pavlov-Burdenko theory. The torpid phase is characterized by the suppression of all vital functions of the body. The transition to excitation into inhibition in different parts of the nervous system does not occur simultaneously, but in this regard, some foci of inhibition continue to coexist with foci of excitation. The weakening and disappearance of pain in the torpid phase indicate that pain impulses do not reach the cerebral cortex, and if they do, then there is no response due to the absence of neurotransmitters and does not manifest as a result of a feeling of pain. They are blocked somewhere along the way in the ascending paths. The bark and subcortex do not have the necessary regulating effect on the vital activity of the organism. The course of the torpid phase has a special specification due to the nature of the localization of damage and caused the development of shock. This is how Pirogov once described the torpid phase of traumatic shock. With a severed arm or leg, such a stiff person lies motionless at the dressing station. At that time, people who were in a state of shock were called numb. He does not shout, does not scream, does not complain, does not take part in anything and does not demand anything. The body is cold, the face is pale, like a corpse, the gaze is fixed, turned into the distance, the pulse is like a thread, barely noticeable under the fingers and with frequent intermixing, that is, the so-called intermittent pulse. That is, then we feel it, then we don't feel it. Plus, you see, in this case, the pallor of the character is clearly described, say, the phenomenon of acrocyanosis, the phenomenon of lowering blood pressure, because the pulse is like a thread, that is, it is very low filling. Let's continue Pirogov's thought. On the question, the numb person either does not answer the questions at all, and then or only to himself in a barely audible whisper. Breathing is also barely noticeable, that is, we are talking about shallow breathing, we are talking about a powerful, let's say, inhibition in terms of higher nervous activity. He does not answer questions, or his reaction to a verbal stimulus is extremely reduced. The wound and skin are almost all insensitive. But if a large nerve hanging in the rudder is irritated by something, then the patient shows signs of feelings by one slight contraction of the facial muscles. That is, note, such a powerful pain stimulus as well, in this case, not even the word palpation, yes, as irritation of the exposed nerve sticking out of the wound affects only such an effect by a slight contraction of the facial muscles. In the case of a healthy organism that is not in a state of shock, of course, there was a much brighter reaction. Sometimes this condition goes away after a few hours from the use of stimulants. Well, there were attempts then to treat like this. Sometimes it continues until the death of the victim. So, in terms of the clinical picture of traumatic shock, shock is divided into 3 degrees, and some authors divide it into 4 degrees of severity. Let's start with a mild degree, the first degree of shock, slight shock. What are the clinical manifestations? So, the assessment of higher nervous activity. The patient is inhibited, he answers questions, but there is clearly a reluctance to make contact. A masked face is noted during examination. Body temperature is usually normal, pain sensitivity is somewhat reduced. The heart rate increases, while still up to quite reasonable figures, somewhere up to 100 beats per minute. Systolic blood pressure also drops to a figure of about 95 mm of mercury, and the very scissors that many people talk about occur when the pulse rate begins to exceed the frequency of systolic blood pressure. That is, the ratio of one to the other, which in the literature is called the Algova shock index, becomes equal to 1, that is, 100 divided by 100. Breathing movement. Breathing movements are deep enough, not shallow, but frequent breathing. That is, BH, the frequency of respiratory movements increases somewhere to the figure of 25 beats per minute. Breathing is rhythmic. Second degree. Shock of moderate severity. The situation with higher nervous activity worsens. The patient is inhibited, he has a sluggish reaction to others. He hardly makes contact. The skin is pale, cold, the pupils react weakly to light. The purity of the pulse rises to the figure of 120, 140 beats per minute. The pulse is weak, systolic blood pressure drops below 90 mm of mercury, breathing becomes superficially distinct, shortness of breath. The frequency of respiratory movements on average somewhere increases to 30 respiratory movements per minute. Severe shock. Shock of the third degree of severity. The patient is loaded, inhibited, extremely reluctant to come into contact with medical professionals, reluctant to answer questions. The skin and mucous membranes are sciatic. There is a cold fine sweat on the surface of the skin, the pupils are sharply dilated, they react sluggishly to light, skin reflexes are reduced, tendon reflexes are reduced. The pulse rate rises to 130 beats per minute. The pulse is thready, difficult to count. In fact, it can really be counted only on the main vessels, somewhere in the area of the carotid artery. Systolic blood pressure drops below the figures of 70 mm of the standard column. You need to clearly define this boundary. The boundary of 70 mm of mercury in terms of pathogenesis indicates that filtration in the kidneys stops. It is the figure of 70 mm of mercury column that is the pressure gradient in the renal membrane at which the liquid begins to sweat and primary urine forms. That is, by lowering the pressure below 70 mm of mercury, a full-fledged vicious circle is activated, in which intoxication of the body that occurs during shock leads to a decrease in blood pressure, to a violation of hemodynamics. A decrease below 70 leads to the fact that intoxication begins to increase sharply, the circle is spinning. Sometimes this figure of 70 is defined as an irrevocable shock. That is, if the patient's treatment program is not changed now, it will be extremely difficult to return him. Shortness of breath, distinct shallow breathing. Breathing is rhythmic, but the frequency of respiratory movements is beginning to approach a rather serious figure, 40 movements per minute. In the absence of proper treatment, a terminal condition may occur. Sometimes some authors singled him out in the fourth degree of shock, extremely severe. Now it is customary to call this a terminal state. And what forms of terminal states can be found here? The preagonial state is characterized by confused consciousness, sopor. Sick. The patient's blood pressure is not determined by traditional methods, the pulse is thread-like, it is not palpable, that is, it is constantly lost. The presence of pressure can be assessed by the central method by manometry. The central venous pressure is so-called to assess. Cyanosis increases. Breathing is shallow, frequent, but still rhythmic. The heart rate and breathing rhythm are preserved. This is critically important because it suggests that in the absence of proper nutrition of the brain, with all the desire, the deep structures of the brain are still being fed, that is, the respiratory vessel motor centers are still alive. But the violation of consciousness suggests that the nutrition of the cerebral cortex, unfortunately, has already suffered greatly, and the genius state is what follows after precolony. The absence of consciousness is complete. There are no eye reflexes, reactions to external stimuli. Pupils are dilated, pupillary reflex is absent. Bradyarrhythmia is noted. What can it mean? This means that the cardiovascular center located in the medulla oblongata is experiencing such serious ischemia that it stops sending control signals to the heart muscle. Naturally, the heart muscle in this case, without experiencing a stimulating effect, enters a state of bradycardia. There is no need to contract in a crazy rhythm. The pulse is felt in this case only on large arteries. Problems begin with the blood supply, with the nutrition of the respiratory center, also located in the medulla oblongata. That is, these are the deepest structures of our brain. Breathing is rare, breathing is convulsive and not rhythmic, the so-called Cheyne-Stokes breathing, when 2 or 3 breaths can come for one exhalation. That is, if you look at this case from the outside, sometimes it will seem that an unconscious patient hiccups. He tries to inhale several times in a row. In the next stage there will be a clinical death, a complete stop of blood circulation, respiration and, in fact, the time at which 5 to 6 minutes are released before brain death. If during this time we do not carry out a full-fledged resuscitation, do not restart the work of the heart, brain cells will die and clinical death will turn into biological death after some time. So, we looked at the clinic of shock by severity. Diagnosis of shock. What are the main fundamental components of the indicator diagnostics that should be evaluated diagnostically? Here, on this slide, several of them are presented. So, the definition of arterial systolic and diastolic pressure. Basically, of course, we will be interested in systolic. Determination of heart rate. Here it is marked by the term pulse. Accordingly, assessing the pulse, of course, the rhythm of the pulse, the intensity of filling, and so on. The third point is the determination of central venous pressure. Normally, this indicator is equal to 40 dashes of 100 mm of water column. It can be determined only in the conditions of the intensive care unit after the central vein has been catalyzed, that is, the subclavian vein has been catalyzed. Determination of hourly diarrhea. Normally, 25 to 30 milliliters per hour of urine in a healthy person should be allocated. It is determined by placing a catheter and naturally taking into account the volume of urine being discharged. Determination of the electrolyte in the blood, especially we are interested in sodium and potassium ions, determination of the acid-base state. These are laboratory indicators. The definition of the CC with you and me was considered at the last lecture in the section of blood loss assessment, and it was said that the methods are not fully widely used to the end. Yes, there are dilution techniques, dilution of radionuclide, dilution of dye, but with all the desire at the moment, such techniques have not yet been widely used. The impedance measurement, which was used to estimate the volume of circulating blood, has a fairly strong error. The Algova shock index, which was discussed 3 slides ago. The ratio of heart rate purity to systolic blood pressure. Usually, a healthy person's normal is within 0.5, that is, if you take a pulse of 60, a pressure of 120, I'm not saying that this is for all people, but still this is a variant of the norm, then the ratio of one to the other is 0.5. Developing shock, beginning shock, mild and then moderate severity. The scissors begin to appear, the heart rate increases, the systolic blood pressure of the number 1 decreases. The average degree of the figure is 1.5, then we will see an increase in the Algova index even with a severe shock. At this stage, we see the proportion of the deficit in the volume of circulating blood, depending on the magnitude of the shock. The indicator is used in this case to assess the need for infusion therapy. So, let's continue to consider the moments of diagnosis. There is a very easy, fairly simple capillary filling test, or the so-called white spot symptom. It allows you to evaluate capillary perfusion by pressing on the fingernail. In this case, as you understand, the nail plate should be transparent. The skin is either on the earlobe. Normally, after we release our impact with you, the color, naturally for a given place, is restored in about 2 seconds. If the color is restored after a longer amount of time, 3 or more seconds from pale to normal shade, then we are talking about a decrease in the filling of capillaries. Percent of CVD central venous pressure we have already said. The pressure indicator evaluates the filling capacity of the right ventricle and reflects its pumping function. As we said, normally the CVD is within 60 to 120 mm of a water column. A decrease in central venous pressure below these limits indicates hyperlimia. Clockwise, which was mentioned again, reflects the level of tissue perfusion, the degree of filling of the vascular bed. That is, normally 0.5 dashes of 1 milliliter per kilogram of the patient's body weight of urine should be produced. A decrease in diuresis below 0.5 milliliters per kilogram per hour indicates a lack of blood supply to the kidneys. So, let's move on to an important section, the section of treatment and prevention of traumatic shock. In principle, the prevention of treatment can be divided into 4 large groups. The first is the elimination of the neuropsychiatric component of the injury in traumatic shock. The second is the elimination of the consequences of shelter and plasma loss. The third is the elimination of gas exchange disorders. And the fourth is the elimination of metabolic disorders. So, first aid for traumatic shock. Assistance that can be provided directly at the scene of injury, assistance that can be provided by an ambulance team that has arrived, assistance that can and should be provided by any medical professional who is faced with a situation threatening or already existing traumatic shock. The main purpose of these measures is prevention. Prevention of the occurrence, prevention of aggravation of the course of shock. So, a temporary stop of bleeding. Injections of analgesics available to us right now. In most cases, not narcotic analgesics. Narcotic analgesics during first aid can only be, probably, with the ambulance crew, or if the action takes place somewhere in the hospital waiting room. Applying a bandage to a wound or on an occlusive dressing in the presence of a chest wound with an open pneumothorax and mobilizing the injured part of our body, the limbs are trained by improvised means. Prevention of asphyxia by releasing the oral cavity, by fixing the tongue, by rationally laying the patient and preventing choking with mouth masses if we have vomiting in this case. So, pre-medical medical care. Assistance is provided by a paramedic, an ambulance paramedic in the case of a paramedic brigade, or a paramedic of a paramedic obstetric station. It provides support for the functions of vital organs, stopping bleeding, fighting respiratory disorders. To accomplish these tasks, the following activities can be applied. The fight against respiratory disorders is inhalation with a portable oxygen device. That is, note, in this case, it is necessary to give moistened oxygen. That is, in the artificial ventilation apparatus, in this case, liquid should be poured into the same bulbulator. Temporary stop of bleeding. Applying a tourniquet. Monitoring the indications of their application of the tourniquet. Remember, we discussed at the last lecture the situation with the time that you can hold the tourniquet, and if this time interval is exceeded, remove the tourniquet and use the finger pressing method. Applying a sealing bandage with the mothorax open in it. Administration of analgesics, vascular drugs, respiratory analgesics, and mobilization. Yes, a hot drink dacha. So, first aid is an action that a doctor can take in the event of a situation with the development of traumatic shock. The fight against asphyxia up to intubation, up to carnicotomy and tracheostomy. Temporary stop of external bleeding. At the same time, it is necessary to avoid reapplying the tourniquet. Carrying out Novocaine blockades, if we have sterile conditions, in a dressing room or operating room. Repeated administration of analgesics. Drug therapy of disorders of vital functions, infusion therapy provided that bleeding stops until the state of transportability is maintained. Hot drink. Carrying out artificial lung ventilation with portable breathing apparatus. We talked about the conditions on the previous pile. When transporting hospital patients to the intensive care unit, it is necessary to provide maintenance therapy directly on the way, during the patient's transportation. Particular attention in the provision of first aid should be paid to infusion therapy as one, probably, of the most important moments in the provision of therapeutic measures. So, when providing first aid, infusion therapy is used to stabilize hemodynamics for the period of transportation of the wounded to the next stage of medical evacuation, in particular, say, until qualified medical care is provided. In case of traumatic shock, infusion therapy begins with a jet injection of solutions into peripheral veins with a volumetric injection rate of at least 150 ml per minute. At the same time, it is preferable to introduce solutions of hydroxy of starches, that is, colloidal blood substitutes in combination with colloidal blood substitutes in a ratio of 1 to 1, 1 to 1.5. After stabilizing the systolic pressure at the figures of 90 mm of mercury, you can switch to drip injection of solutions. So, infusion therapy at the stage of first aid. At this stage of assistance, an intravenous jet drip method of conducting infusion solution should be used by puncturing one of the superficial veins in the area of the elbow or forearm. It is optimal to install not a puncture needle, but a peripheral catheter, which is presented here in the illustrations in this slide. Catheterization of superficial veins. The classification of color peripheral catheters and the possible flow rate through the catheter of milliliters per minute is also presented. As we have already said, the optimal figures in our case are 150 milliliters per minute, so the ideal is to install a gray catheter, in the worst case a green one. Thinner catheters will be less effective and, of course, can be used, but mostly in pediatric first aid practice and not in adult traumatology and intensive care. There are alternative methods of administering infusion drugs at the stage of first aid. This is a method of intraosseous injection. The difficulty lies in the need for a special needle with a mandrel, or now in a modern pistol syringe, which will be described a little later, for intraosseous injection. There is also a method of injecting infusion agents into the cavernous bodies of the penis. It is very difficult to meet a special distribution or description of the methodology as such, but the essence of the method is quite simple. Simply inserting a thick needle or catheter directly into the cavernous bodies. There is no difficulty here, but the method is applicable only to men. Definitely you get into the cavernous bodies, there is no such complexity and therefore you are in a venous bed. Infusion can be performed. So, let's talk about the intraosseous injection label using such things as Big Bon and Yakshin gun, a syringe gun for intraosseous injection. In this case, a blue version for adults is presented at the wedding. During the seminar sessions, you will be asked to watch a video in which both a pediatric red syringe gun and an adult blue one will be demonstrated. You will also be asked to evaluate, view, and remember the methods of intraosseous infusion. Please take this seriously enough. The method is not yet widespread in our country, but this medical equipment is coming to our country. Active developments are underway to create their own analogues. At least, I had experience of communicating with military doctors, and a situation was stipulated that more than a year ago there were technical tasks for the manufacture of an analog of this medical device. The BIC syringe gun is used in cases where it is impossible to provide traditional intravascular access for appropriate treatment. The procedure itself is extremely simple. Yes, the time is really spent less than 1 minute. All this is safe and fairly painless. After that, it is possible to transfuse infusion media, or even transfusion media, that is, it is suitable for such access for blood transfusion. It is possible to use rapid fluid infusions. In this case, there is some difficulty, because the flow of fluid directly into the bone bed is difficult enough at a high speed, so it is necessary to create pressure. Usually, this device comes with something called a pressure tank, a bag for creating pressure, and this allows us to enter it quickly enough. Let's look at the methodology itself in the seminar classes. How did I decide in this lecture to consider with you the use of intraosseous access using the big apparatus, that is, Bon Yakshin gun? Puncture points for intraosseous access which are traditionally used. So, for an adult, that is, a modification of this very intraosseous gun of blue color, that is, blue markings with a needle thickness of 15 G with a needle scoring depth of up to 2.5 centimeters. The most commonly used point is the maximum section larger than the tibia. Here is a schematic representation of the location of this point, and then we will be with you in a few slides. After that we will watch a video clip where they will show you again how to find it all and how to do it. So, from the lower pole there is more tuberosity of the tibia to retreat medially, that is, 2 cm in the inner direction, and shift the point by as much as 1 cm. The depth of needle insertion is traditionally set at 2.5 cm, and this access is most often used in adults. A little less often, or rather even much less often, access to the head of the humerus is used. After bringing the arm to the trunk with the elbow positioned somewhat behind and with the palm placed on the stomach, step back from the middle of the connecting line, and in addition it and the beak-shaped process in the shoulder blade down, that is, right along the surface of the head of the humerus, well, somewhere on the order of 2 fingers, and shift forward a little by 1 finger. Here will be a point for inserting a needle to a depth of 2.5 cm using a blue pistol, that is, an adult pistol. Even rarer accesses, which even somehow I actually only saw for the first time, which can be used on the distal part more than the tibia at the base of the medial ankle, and you can step back up, that is, the central ones are 1 or 2 cm larger than the tibia, and also insert a needle here. Or there is a technique for insertion into the distal part of the radius. On the back of the forearm, on the radius, determine the zone opposite to the best definition of the pulsation of the radial artery, and the depth of needle insertion here is quite small, 1.5 cm, and, as far as I remember, traditional blue runs, that is, they basically do not allow us to somehow regulate the depth of penetration. That is, the depth of penetration between you and me is regulated only on a child's pistol. Here at the next wedding we will look at how it is possible for children to do this. So, at the age of 12, the red big gun allows us, using a thinner 18G needle, to measure and change the depth of its penetration into the bone. And, accordingly, depending on the age of the patient, this needle is directly exposed on the gun itself. We will see it with you at the next weddings. At the age of 0 to 3 years, it is hammered to a depth of 0.5 to 0.7 cm. At the age of 3 to 6 years, this is 1.5 cm. From 6 to 12 years, respectively, 1.5 cm. After 12 years, a blue adult pistol is used. The point for the child is described in the instructions only 1. This is the proximal section larger than the tibia. From the lower pole of the tuberosity more than the tibia recede medially 1 or 2 cm, but depending on the age of the patient, and not proximally, but distally, so as not to get into the germinal zone, that is, the bottom 1 or 2 cm. The depth of needle insertion, respectively, before performing the intraosseous injection itself, it is set in advance. Well, let's take a look and analyze the technique of performing an intraosseous injection by itself. So, the first stage for you and me will be, respectively, the definition of the point for puncture. Well, pay attention, those same red and blue guns are shown here for intraosseous injection, that is, the devices themselves. Well, here is a blue big dummy of an adult. They feel the same tuberosity larger than the tibia. Yes, they determine the point of introduction, as we have already said, by 2 cm in the medial and now in the central direction, that is, in the proximal direction. The finger will be shifted in the person who demonstrates it to us, thereby 1 cm. This point is just for the insertion of a needle in an adult. The injection point should be treated with an antiseptic solution. There is usually a napkin with an antiseptic containing iodine included with the gun. Here you and I are presented, well, the dummy of the child is 1-2 centimeters ideally from the lower part of the bumpiness more than the pepper bone and the lateral direction, respectively, 1 centimeter is shifted. They find this point in their hands. Here is a man who demonstrates holding a red gun. Here he sets the depth, see, like this by rotation. After that, they will repeat to us again, depending on the age, what depth you and I need to put on the gun. So, the first action is to determine the point. The sterile packaging is opened. After the skin is processed, the device is pressed tightly. You see, we have a red check, such and such a protective bracket. Yes, that is, it will now be smoothly removed from the device. Do not throw it away, it will still be useful, and after that, in principle, it will not be necessary to put too much pressure on the distal end of the device in order for the shot to work and the spring to hammer the needle. Well, now they will show us. Everything, the action is done, after which you need to carefully remove the plastic casing itself, leaving a fig with a mandrel. Yes, then the mandrel can be removed, yes, directly from the needle itself, and the needle itself must be fixed to the surface of the skin. That's exactly where the plastic bracket will come in handy. She is dressed like this on the tip of the needle, after which the needle is fixed with a band-aid, but she did not swing, did not stagger. After that, you will need to attach the syringe to the needle, pull the plunger on yourself so that the bloody contents appear. Yes, that is, it will say that we are in the spongy substance of the bone. Even if there is no bloody content, this is not a reason to panic. We are really in the dice with you. Here he connects a syringe or a system by himself through an adapter. Well, you can first, there is such a rule, you need to inject about 10 or 20 milliliters of saline very quickly under pressure directly into the spongy substance of the bone, in order to make such a cavity at the end of the needle for you and me, yes, in the spongy substance, so that our infusion can be carried out qualitatively enough. It is necessary to begin the introduction of the drug requirements of the substance, yes, even if we wish, whether in drip or infusion form, we have to use artificial pressure from it, and most often we have to use either an infusion cuff, from which we can create a pressure of up to 300 millimeters of mercury. At the end of the video, you and I were shown how to remove the needle. That is, during the infusion process, it is necessary to control the position of the needle and the absence of infiltration of soft tissues in the puncture area. If there are signs of soft tissue infiltration in the puncture area, it is necessary to remove the intraosseous needle using the same protective bracket. Here now we could see how the needle was taken out. After that, a septic dressing is applied and this bone cannot be used for infusions during the day. Accordingly, at the end of the infusion, one of the requirements is that the needle in the bone can be up to 6 hours. This is usually enough for resuscitation. After this period, it will naturally also be removed from the bone. Here at this wedding is just what is shown in English in the instructions is called a Prosher tank, that is, it is an infusion cuff to create pressure in the system. Well, you see, there is a cuff with a pair and a pressure gauge. There is a pocket in it, a package with an infusion, well, or even with an infusion medium is immersed in this pocket. Naturally, the package is plastic, soft, and this package is inflated, after which we note, that is, drip or jet intraosseous, well, that is, the penetration of the solution. Let's talk about the most frequent and dangerous mistakes during infusion therapy at the first aid stage. One of the fairly common mistakes is the appointment of vasopressors of norepinephrine from the backwater with untreated hyperlimia. For some reason, many doctors believe in this case that the use of these drugs will allow us to raise blood pressure and solve the problem with severe hypertension in shock. You have just analyzed the pathogenesis and you understand perfectly well that in this case we have a decrease in the cc and the problem of pressure drop is related to this. Therefore, the main point is still the elimination of hyperemia by increasing the volume of circulating blood. The next mistake is the introduction of excessive doses, more than half a liter of polyglucine, riopolyglucine in our case, and starch hydroxide with unstoppable bleeding. More than once, in practical classes, we talked about the fact that polyglucine is a rheological drug. It improves the aggregate state of the cellular elements of the blood, simplifies the flow of blood. Hydroxyl starches are even more effective in terms of antiplatelet effect. Polyglucine also has such properties. That is, with unstoppable bleeding, the introduction of large doses of these drugs will worsen thrombosis. In this case, we need thrombosis to stop the bleeding. Conclusion: stopping bleeding by available methods and the use of infusion therapy should correlate with each other. The next mistake is the introduction of old, let's say, colloidal solutions without conducting a biological test. Many people spit on this situation in case of an emergency and can really get problems later. At the previous lecture, statistical figures were indicated in the table, for example, talking about anaphylaxis when using the glucine field, with anaphylaxis when using gelatinol derivatives, and the figures there were quite large. At the same time, modern colloidal solutions, such as GETI or polyethylene glycol derivatives, have an extremely low percentage of anaphylaxis and, if desired, they can just be used without conducting a biological test. Another mistake is the delay in the evacuation of the wounded for infusion therapy. For some reason, many people believe that carrying out infusion therapy during transportation can have an extremely negative effect on the patient's condition. After all, modern reanimobiles and the conditions of the modern road network suggest that transportation will not be as traumatic as it might have seemed earlier, when we had rough terrain, a horse and the like. There is another mistake: it is the termination of infusion therapy in connection with evacuation. Well, you noticed that this is very similar to what we just said before. You shouldn't do that either. Let's look at infusion therapy at the stage of providing qualified medical care. The overall rate of infusion in this case should be such as to make up for the deficit from the central committee by 70 to 80% during the first hour. We talked about the volume deficit a few slides above when we evaluated the Algova shock index and talked about the percentage shortage from the central committee. A prerequisite, especially for large volumes of infusion of liquids, this should have been said a few slides ago, is the need to warm them up to human body temperature. The introduction of a liquid at a temperature of 24 to 25 degrees, that is, the environment in large volumes at high speed, can cause a cold cardiac arrest. This must be remembered. During the course of the clinical criteria for restoring a sufficient volume of circulating blood, various indicators can be used, in particular, an increase in the hourly cut to 45 to 50 milliliters per hour, stabilization of central venous pressure at the figures of 80 to 100 millimeters of water column, restoration of normal blood pressure figures, reduction of pulse to physiological values, reduction of skin rectal gradient up to 1 degree. Normalization of the color of nail spoons. The choice of the route of administration of infusion-transfusion agents at the stage of qualified care, as well as at the stage of specialized medical care, if assistance is provided in the intensive care unit or in a specialized trauma center. Two paths are required. This is the path of catheterization of peripheral veins, we considered it a few slides ago, and the path of catheterization of the central vein. That is, mainly, by the way, it is the catalysis of the central vein. This is usually the subclavian vein. The technique is performed by a special doctor, resuscitator, and this technique has a number of advantages. Firstly, it is the possibility of an extremely long, up to several months of using a single access to the venous bed, the possibility of massive infusions of various drugs at a rate of up to several liters per hour. the possibility of introducing almost any, even highly osmolar infusion media, the possibility of blood sampling for analysis, and the possibility of measuring the very central venous pressure, which is often necessary, because it is a very important criterion for assessing hemodynamics. The possibility of X-ray ultrasound control of the catheter location. This is also important enough to avoid complications directly from catheterization. What drugs are used for infusion therapy? At the last lecture, we analyzed a number of things, especially colloids to perform, that is, blood substitutes. In the classroom, we will also devote a lot of time to this. A number of people will perform independent work in the form of reports. But it's still worth a run. So, natural colloids, volumes of replacement drugs, that is, thalamics. This is freshly frozen plasma. Yes, it is not an infusion medium, it is a transfusion medium, albumin. Another group is synthetic colloidal volumes that replace solutions. We start in chronological order. Gelatin derivatives, one of the first to appear, are probably the era of the 50s and 60s. With all the desire, some of them are still widely applicable to this day. Let's say gelofundin was present in KB number 8 back in that year. So, these are solutions of oxygelatin, solutions of liquid modified gelatin, yes? Dextrins. Dextrins have not lost their significance to this day. These are drugs that have been the drugs of choice for decades, and the most famous of them are the glitches field. This is a medium molecular dextra, low molecular dextra. The most beloved of them, probably the most beloved of the blood substitutes among students, is riopolyglyakin. Honestly, I don't know the reason why they love him so much. Yes, the drug has volume substituting properties, but to a greater extent it is still rheological, say, rheological drugs that improve microcirculation. The drugs that are currently the drugs of choice are derivatives of hydroxy in starches, high molecular derivatives with, let's say, an optical density index of 450 kilodaltons, that is, these are high molecular media. This is Gispen, stabazole, which is quite widely found in our country. On average, molecular here, probably the most famous of all this is Reformtab. Low molecular environments are also present. Another large group of blood substitutes include crystalloid, or they are also called target substitutes. Here the classification according to the resin is applied. There are hypotonic solutions, and a 5% glucose or dextrose solution refers specifically to a hypotonic solution. Anzatonic solutions. The most famous of them is a banal saline solution, a 0.9% solution of sodium chloride. More completely, it is dis-trisol, Ringer's solution, in which there is also a variant of sodium bicarbonate which allows us to fight acidosis. Plasmolite, hypertonic solutions, well, let's say, a 7.5% sodium chloride solution. The main advantage of crystalloid salt blood substitutes is the ease of transfusion tolerance, their non-activity, that is, the impact on our body is completely reduced. There is no effect on kidney function, on the immune system. Yes, there is no risk of an anaphylactic reaction. Balanced salt solutions, as I have already said, Ringer's solution or plasmolite maintain the electrolyte balance in our body. There are disadvantages of crucoid volume substituting solutions. They are redistributed relatively quickly from the vascular bed. They go into the intercellular space literally in 1 or 2 hours. 3/4 of the saline solution turns out to be in the antisocial space. The most common mistakes during infusion-transfusion therapy at the stages of providing qualified and specialized care are the following things: overestimation of the informativeness of some hematological indicators, that is, the concentration of red blood cells, hemoglobin, hematocrit, specific gravity of blood in injured with blood loss and untreated dehydration. And also remember, we talked at the last lecture about the first hours. The first or second hour after the injury, that is, until the moment when our hemogram directly reacts to the pronounced loss of blood. The next mistake is to conduct infusion-transfusion therapy without dynamic monitoring of blood circulation parameters, without monitoring blood pressure, without monitoring central venous pressure, without monitoring the composition of peripheral blood. That is, if in the previous paragraph we talked about reassessment and attempts to assess the indicators when they look normal and stop infusion therapy, then in this case there is simply no control over it. Control of erythrocyte concentration, hematocrit, protein content with plasma molarity, clotting time. As a result, there may be insufficient or excessive maintenance of infusion solutions. Another error is the transfusion of blood components without absolute indications. Quite rare at the moment. Recently, doctors are really very much afraid of transfusion of blood components directly. They are afraid of transfusion reactions. We will talk about them with you during the seminar sessions, and people will have reports that they will report in the classroom. Another mistake is the refusal of reinfusion of blood in the absence of absolute contraindications to its use. Reinfusion of blood is a rather interesting technique which may be feasible for injuries associated with precomatous bleeding, when we can talk about the sterility of blood that has poured directly into the cavities of our body. It is possible to pick it up, pass it through plasma filters and return it to our body. In this case, the blood will be authentic, it will be our own for our body, and there is no risk of transfusion complications. We will continue to consider the errors about the infusion-transfusion therapy. The next mistake is the late start of infusion therapy, untimely correction of the deficiency of red blood cells and plasma proteins of the blood. Another mistake is the introduction of colloidal blood substitutes, such as piliglyakin, riopiligyakin, without conducting a biological test and in volumes of more than 1 liter per day. Remember, at the last lecture we considered both the moment of the risks of anaphylactic reaction to these blood carriers, and the moment of harmful effects on the renal membrane of dextrans, and stipulated the thing that the maximum daily dose is 800 milliliters of 1 liter per day. The next mistake is the use of solutions with a pronounced asthmatic effect. Solutions of coin from orbit, Rio, polyglucine, glucan field, riogluman before the elimination of dehydration in the wounded. That is, it should be clearly understood that the use of solutions with a pronounced asthmatic, narcotic effect must necessarily be combined with the use of crystalloid solutions. That is, the volume of liquid that we want to keep in the BCC. If we use only highly osmolar drugs, we can get the opposite situation, when they will seek to bind fluid on themselves and pull it directly from organs, in particular from the brain. Another mistake is the excessively wide indications of central vein catalysis. That is, the execution of this operation by persons who do not have the appropriate skills and training. By itself, the procedure for catheterizing subclavian guilt should be performed by a specialist resuscitator, because there are a number of mistakes that can be made in this case and irreparable consequences and tragic nature. Another mistake is the transfusion of blood components without taking into account the requirements due to serological or immunological compatibility. It seems that almost from the second year they explain to us about the need to observe and understand blood groups, Rh factors, but believe me, in practice, oddly enough, there are still cases when medical professionals make mistakes in such a simple matter as requirements due to serological and immunological compatibility of blood products. This blog presents a fairly old scheme using DECANS, that is, Bluekin software, which was present even at the time of writing the textbook of surgery by Cousin. In this diagram, depending on the degrees of shock, the volume required for replenishment in the central nervous system is presented, as well as the distribution between crystalloid solutions, colloidal solutions, as well as in severe cases of shock and blood preparations in this case. A few more words about the features of infusion-transfusion therapy in traumatic shock. The peculiarity of the following. For example, with brain injuries, it is customary to reduce the volume of saline solutions, reduce to digits twice. The reason is that with a brain injury, there is a risk of edema, swelling of the brain. In case of damage to the abdominal organs, the number of blood substitutes, on the contrary, is usually increased to the figure of 30 to 40%. And the reason is that there is a large pathogenetic volume of hypovolemia associated with blood loss in the abdominal cavity. With multiple fractures of the pelvic bones, the volume of hemotransfusion is also increased by 20 to 30%. In the absence of retrocytic mass, it is customary to increase the volume of the introduction of a blood changer, that is, in this way to deal with the situation when we do not have the opportunity to use native, that is, directly authentic for human environments, such as blood preparations, retrocytic mass. In the first 6 hours, it is customary to administer 60 to 70% of the daily dose of the indicated remedy. With this, let me finish the lecture. The first experience we use is such a lecture, well, in connection with our problems with distance learning.